It is extremely important to know what patellar tendonitis looks like in order to diagnose it. Though it is historically difficult to detect on MRIs, some studies have shown that there may be a noticeable thickening in the patellar tendon associated with tendonitis. It may also be visible as a high signal on the MRI. Having a background on the athlete may help to identify the injury. Athletes that engage in activities that require repeated jumping, like basketball, volleyball, and gymnastics, are at a high risk to develop patellar tendonitis. This is why it is extremely important for them to have good jumping mechanics. There are studies that show that an excessive reliance upon quadriceps instead of glutes upon landing can increase the athlete's chances of developing patellar tendinopathy.
Initially, patellar tendonitis tends to present itself as little knee pain during or after exercise. Because of this, athletes tend to shrug it off as normal pain or simply soreness. However, as exercise continues and tendonitis is left untreated, they will notice a drastic change in pain. Although the athlete will have a normal range of motion, they will begin to see common movements where the pain is involved, such as when the knee is extended or quadriceps are relaxed. For example, when the knee extends during squatting, athletes will notice a sudden increase in pain as they come back up. With patellar tendonitis, the knee pain will subside with rest, so individuals may believe that they are feeling better, even though inflammation will increase once activity increases again. The knee pain will also intensify as time and use pass without proper rehabilitation. Sometimes this pain can even be debilitating. In order to rule out other injuries during evaluation, a practitioner will perform two types of physical exams, the passive extension flexion test and the standing active quadriceps test. During the passive extension flexion test, the practitioner will have the patient lie in supination on the examination table and palpate the anterior aspect of the extended knee. The maximal point of tenderness for patellar tendonitis should be located at the origin of the tendon at the inferior pole of the patella. If the tenderness is identified at this particular tendon, the practitioner will ask the patient to flex her knee at a 90-degree angle and palpate again for tenderness. In the standing active quadriceps test, the patient is standing and the practitioner palpates along with the knee in which pain occurs. The point of maximal tenderness should also be identified at the inferior pole of the patella. The patient will then flex the knee at a 30-degree angle and will be repalpated. Most importantly, the individual should note that the pain is reduced during knee flexion versus extension. Another technique practitioners will sometimes utilize is imaging, such as X-rays or MRIs, to make sure there is no tear or fracture to confirm the diagnosis of patellar tendonitis. Occasionally, the tendon will thicken depending on the grade of inflammation and lesions that will show on an MRI or ultrasound. Finally, like most practitioners for most injuries, they will talk to the patient about their medical history and life. For patellar tendonitis, they may be interested in what sports they play and how often they are active.
After diagnosis of patellar tendonitis, the first step to return the individual to their functional activities is treatment of the injury. The main treatment goals for each patient with patellar tendonitis is reducing the inflammation associated with the injury, providing the tendon with the proper healing process, and finally returning the patient to their functional activities. The first step in the treatment process consists of rest and cessation of activity. These two steps allow the patient and the tendon to be alleviated from pain and inflammation in daily life activities or for athletes, the specific activity or sport that causes the pain. After the patient has taken some rest and separated themselves from the aggravating activities, conservative measures can be introduced and performed in the treatment process. Therapeutic exercise is primarily based on patient to patient, with determining factors being the extent of muscle strength, as well as the discovery of length impairments during the initial examination. The different modalities have been performed on patients with patellar tendonitis with the intention of reducing pain and inflammation throughout the treatment process. Pharmacotherapy is utilized as a conservative measure in the early phases of treatment for 1.5 to 2 weeks to alleviate inflammation. Injection treatments vary, with sclerosing destroying abnormal blood vessels and the other 4 stimulating healing within the tendon. If rest, cessation, and the conservative measures do not help, then the next step is surgery of the tendon. The patient would undergo arthroscopic treatment in order for precise debridement and partial resection of the inflamed posterior fibers of the patellar tendon and the Hoffa fat body at the lower patellar pole. Complete resection of the bony tip of the patellar will be added for certain cases. Surgery must be maintained arthroscopically and fluoroscopically to avoid insufficient or excessive resection of the lower patellar pole. The rehabilitation plan consists of 5 stages the patient must undergo to be returned to functional activities from patellar tendonitis. The phases are broken down as Phase 1 as isometric loading, Phase 2 eccentric strengthening, Phase 3 resistance training, Phase 4 sport-specific training, and Phase 5 maintenance. The goal of isometric loading is to reduce the tendon pain and improve muscle performance. This phase will last about 2 to 3 weeks, and markers for recovery is pain is at a level of 5. Exercises included in this phase would be single leg decline squats, heel raises, wall squats, and isometric quadriceps. In the eccentric strengthening phase, the goal would be to strengthen weakened muscles in terms of range of motion and overall musculature. The timeline for this phase would be about 2 to 3 weeks, with markers for recovery being pain is below a 5 and the load tolerance is adequate. Exercises included in this phase would be knee extensions and flexions, leg extensions, sit-to-stands, and split squats. The next phase is resistance training, with the goal being returning energy storage in the tendon. The timeline for this phase is about 3 to 4 weeks, with markers for recovery being load tolerance with jumping exercises. Exercises included in this phase are hack squats, stationary bike, single and double-legged vertical landings. During sport-specific training, the goal is to increase the jumping load and return the patient to minimal to moderate activities. The timeline for this phase is about 3 to 4 weeks, with markers for recovery being pain is minimal, load is manageable, and patient can tolerate high-intensity training. Exercises within this phase include squat jumps, single leg hops, death jumps, and lateral hide-ins. The final phase of rehabilitation is maintenance. The goal of this phase is to fully return the patient to their sport or daily functional activities. The timeline for this phase is about 4 to 5 weeks, with markers for recovery being pain subsides completely. Exercises that can be included in this phase are all exercises that have been previously used in the prior phases.